Welcome back. Let's continue with the investigations that can be done for branch retinal artery occlusion. To further investigate the BRAO, it will be important to take a thorough history to find the underlying cause behind this disease. For vitals, it's very important to check the blood pressure. Also check the vision pressure in pupils with special attention to pupillary reflexes to light. And also it will be a valuable test to perform visual fields. We should also check for any history of arteriosclerosis, any family history of high cholesterol, history of fractures, and any scalp tenderness, temporal pain, and jaw claudication. There are a lot of investigations that can be done for BRAO to find the underlying cause behind the occlusion. In terms of labs, we can check the FBS and the A1C to rule out diabetes, CVCN differential, platelets and the PT-PTT, protein C and S, factor V Leiden mutation, antithrombin 3 to rule out coagulopathy, and the SPEP is for multiple myeloma. ANA, RF are markers for lupus and rheumatoid arthritis, respectively, and sickle cell disease. We can rule that out too. BDRL and the FTA-ABS is for syphilis, and this is especially indicated for patients below 50. FTA-ABS stands for fluorescein treponymal antibody absorption test. Yejun and CRP are inflammatory markers, and we need to do this especially for patients whose age is greater than 50 to rule out AION from giant cell arteritis. Some other investigations include the fluorescein angiography. When administering fluorescein into the bloodstream, if there is delayed or absent retinal arterial filling in one branch or a capillary non-perfusion, this is likely indicating BRAO. OCT can also look at the cross-section of the retinal layer, and if there is thickened and hyperreflective inner retinal layer, this can indicate intracellular, not intercellular, edema. B-scan or an orbital CT can be used to rule out any compressive lesions, because we covered that this can be causing BRAO as well. If the patient has history of high intracranial pressure, such as vomiting, headache, nausea, and papilledema, according to your fundoscopy exam, then we could use B-scan or an orbital CT to see if there are any masses. So with every patient presentation, we should have differential diagnosis. As mentioned before, the retinal whitening could be due to commercial retinae from trauma, and it could actually be a vein instead of an artery, making it a BRVO instead of a BRAO. Without the fluorescein angiogram, we could mistake the CRAO for a BRAO, and CRAO with any branch artery sparing would be an exact opposite to the suspected BRAO. This is more of an urgent matter where everything except for that branch is occluded. Lastly, instead of just the artery, both the artery and the vein could be occluded. So like this picture warning says, this photo contains sensitive content. So if you're not a fan of opening the eyelids with speculum, fast forward a few seconds. BRAO is the occlusion of an artery, and all the tissues need constant perfusion of the blood by the vasculature. So BRAO is a very acute ophthalmic emergency that needs to be treated within at least at the latest a 90-minute window. If it cannot be attended and treated immediately, BRAO can even progress and cause tissue infarction in a way that the vision loss is permanent. The goal of the treatment is to move the emboli away and restore blood flow in that particular area of the retina for vision preservation. The mainstay of the treatment is to lower the intraocular pressure because IOP and the blood pressure needs to be balanced for the tissues to be adequately perfused. Therefore, the net perfusion pressure of the retinal circulation can be increased by lowering the intraocular pressure. This can be done by first trying a digital ocular massage to try to dislodge the clot, and also by using systemic acetazolamide or Diamox. This can be done IV or per oral. Beta blocker, like the timolol, can lower the intraocular pressure as well, and it's usually given topically as 0.5%, one drop every 15 minutes, and repeating as necessary. Anterior chamber paracentesis can also be performed. This immediately lowers the IOP to 0 millimeters of mercury. This procedure can be easily performed at the slit lamp. We prep the eye with the topical anesthetic as well as the broad-spec antibiotic like Vigamox and povidone iodine. You place the lid speculum on the eye as demonstrated in the picture, and the eye is grasped with the forceps at the nasal side of the limbus to hold the eye still, and also countertraction. And then the microsurgical knife or 30 gauge half-inch needle on 1 milliliter syringe without the plunger can be inserted parallel to the iris through the peripheral cornea at the other side of the limbus, the temporal side. And then the aqueous can be released in a controlled fashion. After that is treatment with topical antibiotics, broad spectrum, like the Vigamox, 4 times a day for 3 days. Same thing here. The picture contains sensitive content, and if you find holding the eye open with speculum and injecting something disturbing, then fast forward a few seconds. It seems like I've gotten ahead of myself here. These are the specific procedures of the anterior chamber paracentesis written out in steps for you. We can also consider hospitalization of the patient for carbogen. This is 95% oxygen and 5% CO2, which can increase oxygenation and vasodilation as well. And hopefully the vasodilation can dislodge the clot. If giant cell arteritis is suspected, we will give systemic steroids, methylprednisolone, 1 hour IV, 4 times a day for 3 days with a very slow taper. After 3 days, no more than 2.5 milligrams of decrease per week. In this iPiece, we've learned the investigations and treatments that can be done for BRAO. In the next and final iPiece, we will discuss the carotid artery disease and how that can relate to BRAO.